Welcome to this symposium sponsored by Abbott, where we are going to delve into 21st century valve therapies. I'd like to thank the sponsors, the SCTS, and especially to our four speakers, Mr. Nour Al-Attar from Glasgow, Professor Maurice from Belgium, Joe Zacharias from Blackpool, and Gridal from Bergen for giving up their time to come along and give us their views. If you have any questions, we will ask the presenters at the end of each presentation, and I'd appreciate if you could put the questions on the Q&A. So I'd like to introduce Nour Al-Attar. Most of you will know he's a cardiac and transplant surgeon at the Golden Jubilee, and I'm sure that what he's going to tell us is going to be fascinating. So Nour, over to you. Thank you.
Thank you very much, and good evening, everyone. So just take my slides. The trifecta valve has a specific design, and that specificity allows it a near cylindrical opening, which offers an enormous effective airforce area. And with that, quite low gradients. And you can see here that these gradients tend to persist over time. That specific design is such that the pericardium is wrapped outside the stent. And indeed, the intent was to provide optimal hemodynamic performances. You can see again on this bar chart, very low gradients despite small valve sizes, and the persistence of these gradients over time, over a 10-year period. And now these optimal hemodynamics, these low gradients, have the potential advantage of a lower rate of severe patient-prosthesis mismatch, a quicker or a faster and a better left ventricular mass regression, and the clinical consequences that can follow in terms of low risk of rehospitalization and improved survival. And indeed, this is a very recent publication from the Cleveland Clinic, which compared the trifecta to the Paramount valve. And indeed, in the first 5 years, you can see that this very low gradient did have an impact on the left ventricular mass index, and this fell faster with the trifecta valve compared to the Paramount valve. However, it seems that this valve design may also be associated with a certain risk, and I'm sure we've all been recipients of this alert that came out from the MHRA last year, where there were a report of a higher number of incidents, particularly for the first generation of the trifecta valve, and a few for the next generation over the last, since 2010. Now, as a result of this alert, we decided to audit our valves. But so that we speak the same language, I just wanted to review quickly the different, what this alert was about and the different generations of the valve. Now, the alert was on non-calcific leaflet tears. And you can see the incidence of these in the first generation trifecta that came out in 2005, was in use until 2015, was around 0.3%. But there have been iterations of the trifecta valve, and the most recent iteration is the trifecta GT with an updated holder that came out last year. There's also been changes around how the pericardium was wrapped around the stent with an alignment to reduce the risk of NCLT, so these leaflet tears. So on that basis, we decided to look at all the valves, all the trifecta valves that we implanted over since in fact October 2011, so over a 10-year period. And we wanted to look at structural valve deterioration using as a clinical surrogate for that the risk of, the need for redo aortic valve replacement. Now, this is obviously a retrospective study, so we interrogated our database, the database that's completed in a prospective manner and is independently verified by our audit team. We obtained the necessary approvals and, as I said, included all patients who had a trifecta valve, trifecta biprosthesis, since October 2011, which is the day we started using the valve. Our primary outcome was the need for a redo operation. And I'm sure many of you are aware of the distribution of referrals in Scotland, but we tend to take the west of Scotland. Patients from the west of Scotland are referred to Glasgow, and obviously the east to Edinburgh and the north to Aberdeen. So we were expecting that all redos would return back to our centre if they had surgery, unless they had obviously moved or their outcome was different. We also decided to look at our early survival, so the immediate post-op survival, and the time for redo. These are our results. So we included a total of 944 patients. The mean age, as you can see, is similar to what you would expect in patients requiring bioprosthesis, so just over 70. The majority of valves were native valves. This was an AVR for native valves, but there were some redos with biological and much less frequently mechanical valves. And aortic stenosis was the main pathology in about just under 80%. These are the characteristics of patients, and I'll summarize them for you in the following slides. So looking at our primary outcome, and which was the need for a redo intervention, 13 patients who had received a trifecta aortic valve underwent a redo procedure in Glasgow. This amounted to 1.4% of all patients. And these are the periop characteristics of the patients who underwent a redo procedure. And again, I will be discussing these in a bit more detail in a moment. The summary of them is that out of these 13, the characteristics were that their mean age was 63, and you'll see, comparing it to the overall population, this was about 10 years younger than the patients who had the AVR, who were part of the overall group. The Euro score was obviously much higher in a redo context than it was for a primary procedure. And again, aortic stenosis was the main pathology in about 2/3, with AR forming less than 8%. So what we noticed was that the form of structural valve deterioration here was more comparable to the standard classical calcification of the valve, with a much smaller percentage of patients having severe AR, which could be explained by the cusp tear. We looked at the, so the differences were, as I said, the mean age, and as I said, there was about a decade of difference, just 9.6 years between patients who came back for a redo operation compared to those who did it. And indeed, the Euro scores were higher in the redo population, although at the time of the primary operation, that did not show as, in fact, they were comparable. We thought that smaller valves would probably degenerate quicker, but we didn't really notice a difference, albeit, of course, in a very small sample size. We didn't notice or we didn't demonstrate valve sizes being a primary outcome or a differentiating factor. And indeed, these are the patients who required a redo, and you can see, while there is a majority of the size 21 and 23, the numbers are indeed small, but the smaller valve definitely did not show an increased incidence. And when you look at the overall sizes implanted, it's definitely the 23 that numerically would have exceeded the others, and we would have expected a higher rate in this particular group. We then, given the small numbers, we individualized each reason for a reintervention, and indeed, out of those 13, 7 patients had an equivocal structural valve deterioration, and 6 patients had infection as a primary cause for reintervention. Regarding our secondary outcomes, so the operative outcomes were obviously a higher rate of higher mortality rate for redo procedures compared to patients who did not require redo intervention. This isn't really interesting, but we looked at the mean time from the time of surgery to reintervention. And if you include all cases, so these are the infections plus the SVDs, it's about 48 months. While if you take away the infections and focus exclusively on re-interventions for structural valve deterioration, so there's 7 patients, then there's just over a year of difference, in fact, a year and a half of difference in that group. There was a small number of patients who required an immediate reoperation. So this was a redo on the same day, at the same time of the initial procedure. And I'll come to discuss these in a moment. I think they're relevant. These are the Kaplan-Meyers for all time to re-intervention in all comers. And if we take away the infections and look exclusively for patients who require re-intervention for structural valve deterioration, you can see, of course, an extended survival. Despite the small numbers, we still wanted to explore whether a first or second generation trifecta had any difference in terms of outcomes. And indeed, you can see here that 2/3 of patients required first generation trifecta, and they formed 11 out of the 13 patients who required re-intervention. So the grand majority of valves were indeed from the first generation trifecta. This was again subdivided by 2/3 requiring coming back for an SVD and about 1/3 for an infection. Obviously, this is also I mean, you need to factor in that these were implanted earlier than, of course, the trifecta GT, which came up a few years later. And indeed, out of the trifecta GTs, which form just under 40% of all trifectas implanted, only 2 required re-intervention. And in fact, both of them, the cause of re-intervention was for an infection. And indeed, this being, of course, a much shorter time for re-intervention compared to an SVD cause. These are the 5 patients I just wanted to touch very briefly upon. One of the things we noticed in this group when we thought that would explain why valves would deteriorate on a more long-term basis was whether, if we were trying to oversize valves at the time of surgery, would this be something that would penalize us later? But in fact, at least for immediate intervention, that does not seem to show as an indicative factor. What we mostly see is that these patients were almost all redos, and they required an additional procedure in the form of a mitral valve. And I wonder whether the distortion of the mitral aortic apron or curtain, and of course the aortic annulus, contributed to that. This, of course, is still a theory. I'm going to summarize quickly by my limitations of the study. This obviously is a retrospective analysis, and although the database was completed in a prospective manner, this still remains retrospective, and therefore, with all the limitations of an observational retrospective study, there's no doubt that taking the need to re-intervene, so the fact this is taking the redo procedures as a primary outcome, this is a very crude indicator of the true incidence of SVDs. We did not perform. We do not have the data for echocardiographic analysis or follow-up throughout this time. Now, as I said earlier, these patients would have been referred back to us unless, of course, they had moved or their outcome was different. But we believe we captured the grand majority of these. TAVI and valve-in-valve TAVI particularly is becoming more and more an option for patients with degenerating aortic valves. But in our case, we hadn't done, at least at the time the audit was completed, we hadn't done any at the Golden Jubilee, knowing that we only started our TAVI program in 2018. And of course, while the maximum follow-up is 10 years, the median may vary. Thank you very much for listening, and I'm happy to take any questions.
That's great. That's great, Nawaz. That's a fantastic presentation. There's not many questions from the audience. So I know you have to go quite soon, so I'm going to say, has your confidence in Trifecta, how do you view the valve now? Who would you put it into, and is it still your primary valve of choice?
So at the time of the alert, I think we all had a bit of a scare, and the valve was, for that moment in time, was withdrawn. It wasn't made available, and we weren't really implanting it. But following this audit and the discussions that we've had amongst us as surgeons, we clearly haven't seen the same outcome that was noticed in the MHRA alert, and certainly not the tears. And even in the patients that did come back from SPD, they were more of the more classical progressive calcification of the valve than the leaflet tear. That was the primary reason for the alert. So the valve is now back on the shelf and it is available for use. We're still obviously a bit cautious. Being a tissue valve, we do tend to reserve it for patients above 75. But I think one of the other lessons that we learned is, given how the stent can be deformed, and of course oversizing is one of the recognized reasons for early valve deterioration. But the other thing that we've kind of picked up is when you do implant a mitral valve, then that distortion of the mitral aortic curtain and probably of the aortic annulus might also result in an early or maybe even a later failure of the valve. So it would probably be for solo aortic valves as opposed to a combined procedure.
Yeah, which leads me on to my second question for you, which is, why do you think, your centre mirrors the results we get at Barts with Trifecta, which are pretty good. Why do you think some centres do have such poor results?
Well, so as I said, I think an attempt to oversize, it's always a quest of a surgeon to put in the largest size that the aortic annulus can accommodate, and sometimes maybe even going a bit beyond that. I think that attempt to oversize has been recognized as one of the reasons. There is a plethora of factors why valves can deteriorate, but again, referring back to the Cleveland Clinic paper, I think putting it in younger patients is something we've certainly noticed. I mean, the cohort of patients who required redo interventions were younger. That, I suppose, is true for all tissue valves, but it could explain why some centers probably were, as I said, maybe employing it in a younger group of patients, hoping that low gradient could be undoubtedly of huge clinical advantage to them. And I think there's not so much doubt about that, but I think it's about the longevity of the valve, the durability that we would have to consider when impacting them in patients in general, really.
Great. Thanks very much. I think in the interest of time, we'll just move on. Thanks very much for your presentation. So next we have Professor Bart Morice, who's a cardiac surgeon in Leuven. I've known Professor Morice for many years. He's a great innovator, and I'm sure we'll have lots to learn from his talk.
Thank you, Kulvinder, for this nice introduction. And I would also like to thank Abbott for the invitation to speak here and to share our experiences with the Trifecta valve, which I think is still a very interesting device given the very nice hemodynamic profile it delivers to many patients. And I think my presentation nicely matches or nicely follows on what has been presented by Nawar, because I'm also going to talk about the innovation that has gone through on the GT version, and also I would like to pinpoint that it's really a pity that this is insufficiently and not explicitly enough emphasized in current literature that is ongoing on Trifecta. Because you all know there have been many recent reports on Trifecta. I mean, it's and some of them have been really good news. I mean, there's some of the larger North American trials that have published their follow-up data, which still show great hemodynamics, and like Nawar has presented the data from Cleveland Clinic on the very nice left ventricular mass regression, which is even superior to the Perimount valve. So very nice data. But there have been some reports as well on early degeneration, on early failures. And I will show you one example here, one of the papers that I've presented. And some failures, they present failures in two different modes. There is, on one hand, they have, like was mentioned, calcific stenosis occurring too rapidly in patients who are really at an advanced age. And on the other hand, there were some very early and sudden cusp ruptures leading to patients needing reintervention on a quite early phase and also on a semi-urgent phase. And these early failures have occurred mainly in the smaller valve sizes, but actually they have occurred throughout the whole spectrum of the valve sizes available. Now, we do have to emphasize that there is a different valve out there now. We are not, when we are implanting Trifecta for the moment, we are not dealing anymore with the first generation Trifecta, but I think in my mind, and I have been looking at a lot of tissue valves, starting from the R&D, starting from the tissue science and the tissue treatment, and I think the Trifecta GT really is a sort of different valve than what the original version was. And why is this? I think it's mainly because of the change of how the leaflets were sutured onto the valve. And I think this is a feature of the valve that is insufficiently known among surgeons, but there has been an optimized leaflet suturing with a better respect of the collagen fiber alignment within this collagen, within this cusps. And I think this is really an important element that will prevent early failures in the future. Next to this optimized leaflet suture, there has been some other minor changes, like the scalloping in the sewing ring, and also the development of this valve holder that can protect the tissue from any damage done during the implantation. Because I'm also convinced that next to the different leaflet orientation, I think there has been some damage done to the Trifecta valves while we were implanting it, either by pushing too hard on the belly of the leaflet here, or by distorting the frame during the implantation. And I think with the new holder that we have now in the GT version, some of these elements are really eliminated, and it is less prone to damage or during the surgery. Also, and you see this here in the bottom of the slide, there's an internal holder that functioned as a backstop to stabilize the stent posts and to minimize stent deformation during implantation. So, similar to what Nawar was sharing with you, we have been fond of the Trifecta since the early days, since 2009, 2010, because we liked the hemodynamics so much, and so we were implanting quite a lot of these valves in the earlier years, and we followed up with the Trifecta GT in the meantime. And so when we were looking at these reports on early failures, we dug it into our own data and to see what we have found in our own series. This is purely retrospective. It's a single center experience. We been using Trifecta from 2010 and looked into data until 2019. And we made the switch between Trifecta and Trifecta GT late 2016, at the end of 2016. My numbers are more limited than Nawar's data, but I think we still have a very similar and interesting message to share. For the sake of time, I'm not going into too deep in the details of the patients, but we have an overall mean follow-up of around 4 to 5 years now. It's increasing, of course, year by year. We have, and this is important to know for this presentation, we have a perfectly similar age range for both groups. So there was no difference there. And also we have the same valve size implanted in both groups. So both the mean and the median valve sizes were perfectly similar between the Trifecta group and the Trifecta GP group. And for the rest, when we looked into baseline profiles like diabetes and COPD and vascular disease, there were no major significant differences in the patient characteristics. So it's really a sort of all-comer experience from Trifecta up to 2016, and then Trifecta GT after 2016. I have to say, and this is similar to what has been reported in the literature reports, we have been seeing in the meantime the need for 23 reinterventions in the original Trifecta group, and 17 of those reinterventions were really for SVD, with the predominance of cusp ruptures there. And as you can see here on this pie slide, these failures happened across through all valve sizes. I have to say 50% were in the 19 and 20 millimeter sized valves, but also quite a big chunk of 23 millimeters sized valves failed. 6 were, of course, for endocarditis, and I think you can completely We don't have to take into account these, because endocarditis on the long run can happen in any kind of tissue valve. But these 17 SVD features are really too early, certainly when you know we are dealing with a mean age of 74, and 8 events of these SVD events happened within the first 4 years of follow-up. So this was also a slightly alarming signal for us, and because I think this is a slightly too high amount in a too short follow-up. What did we do as a reintervention in the trifecta valves? Which we had 17 of those. We had redo surgery in 12 of these patients, and we did 5 TAVRs valve in valve. And I have to say they all went well. So there's no major issue, neither in the redo surgery or in the TAVR valve in valve treatments. Then specifically looking into our GT experience, as you have noticed, of course, the mean follow-up length of time is still limited in the GT. And I have to update this slide in up to 2021, because we were using it since 2016 now. So the curve now goes slightly over the 5-year follow-up. But we see a different story there. Where in the original GT version, we already had several events of SVD, either a cusp rupture or a calcific failure within the first 4 years of follow-up. We don't see this happening in the GT group yet. And we have no events, no reintervention surgical, or no need for any TAVR valve in valve treatment in this GT. And I think this is an important message that we have to keep on spreading. Also, when I look into the literature and when I see other groups reporting on trifecta failures, it is a bit disappointing to see that when you go into the methods of these papers, there is no mentioning on which exact version of the valve they were using during their clinical practice. And when you look at the time frames of implantation, I think most papers that are reporting these failures are talking about the initial trifecta version and not about the trifecta GT group. And this is something I think to take into account for the audience here, and when looking at these papers on early failures. So I'm going to be brief, and in conclusion, I think the first generation of trifecta valve, despite the good hemodynamic profile that it showed and despite the nice gradients that it was able to deliver, it has some early failures, and it has both failures in calcific stenotic disease as in early cusp ruptures. But I have to, from our own experience, and I think Nawar has the same experience, there is a clear difference in early valve failure and need for reintervention between the first generation trifecta and the GT version. In my mind, these design changes have really made a difference in the occurrence of the early failures. There was quite some early cusp ruptures within these early valve failures, and there I have to acknowledge as well that there might be effect of the implant or suturing or suture tying technique that some surgeons use. For example, I have learned from other centers where they systematically use the core knot device and not pushing down on the valve, that they don't see these strange cusp ruptures or early failures in the trifecta group also. So the critical design changes in trifecta GT may be able to prevent these early failures, but of course we need some more years of follow-up to confirm these findings and to re-establish the faith in this tissue valve, which is still providing one of the lowest gradients out there and really superior hemodynamics. And I hope we can deliver this follow-up in the next years to come. Thank you for your attention.
Professor Maurice, thanks very much. That was great. Thanks. In the interest of time, I'll just ask you one question because we still have 2 more presentations to go. Just tell me now, how has your confidence in the valve in the GT changed your practice now? Is it similar to the initial first stage trifecta, or has your confidence come back? And how do you select your patients?
Well, it will take time. I'm going to be very honest. Because we saw this large amount of reintervention in the original trifecta GT, in the original trifecta, even the confidence in the GT was lost a little bit, but we are trying to rebuild it, and we are trying to reuse it in our daily practice. We will use it in a 65 plus age population because of this great hemodynamics. Because when the valve is sized and placed properly, it still gives single-digit mean gradients, and this is still quite unique in the field of tissue valves. So we are slowly rebuilding confidence, but I have to be honest, it takes time, and the more years of follow-up that we will have in the GT version, and the more reports that we will see in literature about the absence of early failures in the GT, will certainly help to rebuild this confidence.
Great, thanks very much. Just two things before I introduce Joe. One is there are polls to rate each of these presentations. I'd be grateful if you could sign into those. And any questions, just put on the Q&A for us. So next we're going to present, well, I'm not, Joe's is a consultant surgeon in Blackpool. And as you know, he's a member of BISMIX and has a great interest in mineral access. And he's going to talk to us about aortic valve replacement, art and science. So Joe, over to you. Thanks very much.
Thank you very much, Kulvinder. Thank you very much to Abbott and SCTS for sponsoring this evening symposium. I'm going to try and rush through this because some of my presentations are, some of my slides are probably a presentation itself, and I'll try and stick to time. So we all know that there are different ways of doing a surgical aortic valve replacement. The open chest sternotomy is standard. It's been around for 40 plus years, and it's a very good technique. And, you know, it's the sort of base on which we have built our experience. Lately, probably over the last 10 to 12 years, we've started moving down the route of hemisternotomy and right anterior thoracotomy. And I personally have gone through the journey of each one of them, and I now am convinced that the nicest way for a patient is to try and do it through what I call an anterior right thoracotomy. So I've just changed it from RAT to ART. Now, I actually originally got interested in this when I saw Matteo Glauber and Solinas doing this, but they used to use central cannulation, and that kind of scared me a little bit. But then I saw Joe Lamellas' presentations and his YouTube videos, and I got reinterested in it, and I thought I'll consider it. And I would recommend everybody reading his work on it, and it's really amazing stuff, and the numbers and the results are truly inspirational, and it has been for me. I unfortunately wasn't able to do everything he did, so he had some instruments which were not available here, and I actually went and watched Vinny Bapat when he was at St. Thomas's, who had actually gone and spent some time in Miami with Joe Lamellas, and we basically came up with a slightly different approach. It still included a second interspace incision, and it did involve disconnecting the third rib right next to the sternum just to give enough space to probably pass tissue valves through. Personally, I was quite comfortable with the peripheral cannulation, which we were using for our minimally invasive mitrals. The external cross clamp was much more familiar to us with our mitral experience, and even though Joe Lamellas used a clamp through the incision, we, and to be fair, Vinny as well, was more comfortable with the external cross clamp, and that's what we went with. Now, we do recommend long shafted instruments. Now, if you're doing minimally invasive mitral, it comes naturally, but I would recommend using those because for the easy ones, you probably don't need it, but for the difficult ones, you would really benefit from it.
Joe, sorry, it's Kulvinder here. We can't see your presentation. I think there's a screen loading error. Do you want to trust?
There's one more element that you need to do in order to select the screen. So we see it that it's loading, but you need to select what screen you're gonna share, and then to press and share.
So
yes, it's okay.
Try that.
Yes, and now go to the presentation, and you won't see us, but we will see your presentation.
Yeah, apologies. Is that better? Can you see my anterior right thoracotomy, my experience?
Yeah, we can, and so can the audience. Yes.
All right. Sorry about that. So So yeah, I'll carry on because this is what I was referring to. So we basically would recommend long-shafted instruments, but for the anterior right thoracotomy approach, they are slightly shorter than the mitral, so they're about 15 to 20 centimeters, and those, you'd be surprised how much of a difference that makes. Now, we were expecting to use predominantly tissue valves, but also in our previous experience, about 20% of patients in our group went for mechanical valves, and basis of that, we decided to go with sutured valves, and I'll expand on that later on. Now, when you come back to Joe Lamellas' paper, he went with peripheral cannulation, and I think in most patients, and I would say 95% of patients, peripheral cannulation is ideal and is safe. We certainly, with our thoracic experience and our anesthetists, were very comfortable with a single lung ventilation, but that's not mandatory. Joe Lamellas doesn't use CT scans, but we certainly went with CT scans, and I'll explain that in more detail. But the one thing that you definitely need is good TOE, whether it's a cardiologist or an anesthetist. Even cannulation requires very good TOE support, and that's something worth investing in. Now, this picture is from Glauber's group, where they basically said the CT scan helps you decide what type of patients would be suitable for the right anterior lateral thoracotomy access, as they called it. And I certainly think type 1A and 1B are straightforward and easy to do with regular instruments. You don't need the specialized long-shafted instruments, but certainly 2B and 3 are much easier if you use the long-shafted instruments. I certainly don't see too many of type 3, and I'm pleased about that in our experience. But the real reason we used CT scan was for two things. One, we were able to pick out patients who had either aortic calcification around the area of clamping or really bad descending disease, as you can see in this picture, and we were able to exclude them because these patients can have a higher risk of stroke for retrograde perfusion. And the other reason we use CT scans to decide which side to cannulate. Now, Joe Lamellas works in a hybrid theater, so he can screen if there's a problem, but these sort of pictures will show you not to pick the side with a big kink in it. And the final reason we are starting to do more and more CT scanning is we're just going straight to CT scanning for a lot of our patients with murmurs. So we don't send them for an angiogram. They just have a CT angiogram. And this is a heart flow analysis of a patient. And you can see how ideal the CT scan and the angiogram are. And so the CT scan does not show disease. We just bypass the whole need for angiogram and go straight to surgery. This particular patient had a stent prior to surgery as a hybrid procedure. Now, there's a short, we've got a series of short videos because there are a few crucial aspects of anterior right thoracotomy, and one of them is the peripheral cannulation. Now, it is important to get familiar with it because it in itself can be a trap. And so, like I said, as long as patients have had a CT scan, you're comfortable that there's not too much calcification, we then do an ultrasound to make sure that, you know, there's no unexpected flaps or untoward features around the femoral artery and vein. And it also helps us decide which one is on top of which. Now, this is my junior colleague doing it, so he's left-handed. But you can see how we're very quickly onto the artery and vein here. That's the vein being exposed. And then we're straight onto the artery. And the nice thing is we always go above the groin crease to just avoid the risk of any lymph nodes being damaged in the process. And then we just put 2 U stitches on the vein, which are perpendicular, and 2 parallel U stitches on the artery. So for interest of time, I'm just going to run through to the next one. So this is the next phase, which will be the chest opening. So again, you can see the incisions about 2 to 2.5 finger breadth long. And this is going from the second rib to the third rib, so traversing the interspace. We then try not to cut muscle, but rather just split it. So we try and split the fibers so that it doesn't hurt too much the next morning. And then once you identify the intercostal space, we basically dissect out the intercostal space gradually. We try not to enter the pleura straight away, because if you did have a bleed from the mammary vein or the mammary artery and the pleura is open, you can lose quite a lot of blood quickly. So we just basically identify the mammary artery, which is here, and we clip it and then divide it. Now, initially in our series, we did this routinely. You don't have to do it as you get more experience. We've stopped, but I certainly would recommend doing this in the initial phase, because the last thing you want either during or at the end of the operation is your mammary artery patients, but I do have to remind them the use.
Okay, I think we seem to have lost Joe there. We'll just see if we can get him back. Joe.
Hi, sorry, did my camera just go off suddenly?
Yeah, and your presentation switched off as well, Joe.
All right. So where was I? Was it the chest opening bit?
You're just dividing the mammary.
All right.
Okay. It's just I must say, it's just that you saw it when it finished the same thing as we did, so it was pretty sharp on there. So now we're gonna need you to share your screen again.
All right.
You're gonna have to do that. I think there was a blip in your connection, and then the whole thing disconnected.
Apologies. I'll share my screen again.
No problem.
So pick that. Share.
Yes. Excellent. And then go to the yes, excellent.
Okay, I'll just show that this is a picture from the Italian group showing what they call a right anterior thoracotomy. We wouldn't recommend this because there's a lot of stretch, a lot of spread. We would rather do a much smaller incision with peripheral cannulation, because most of the surgeons who do this do a central cannulation, but it can be quite sore. The next crucial step of this procedure is external clamping. Like I said, there are a whole host of clamps out there. You can use a Glauber clamp, a Cosgrove clamp, but we kind of have stuck with the Chitwood clamp. The only thing we do is we move it up from where we use it in the mitral position to much higher up to the top of the aorta, so that we have a good area for an aortotomy. I'm going to proceed on to the big question about how we do, should we do sutured valves or sutureless valves? There's a proportion of surgeons who prefer to use sutureless valves for this condition. We actually prefer the sutured valve for many reasons, and we can discuss that if time allows. But we went with sutured valves, and actually we used the trifecta valve for tissue valves and onyx valves for mechanical valves. And we basically take the usual period of de-airing and decalcification. And then for a proportion of patients, we actually used the suturing device made by LSI. It just kind of speeded things up, but we've stopped using it for the time being, just because I'll show you a video of it. These teeth can be, you have to be very careful where they go in. And we kind of decided we'll go back to sutured for the time being with hand sutured valves. But it does give a very good sort of access and a good view. Now, I just want to touch upon this, which is actually a poster, the SCTS. We looked at the two technologies because the business case was made at the same time of sutureless valves and CoreNot and Trifecta, which was the other business case for ART. Now, they're not the same sort of patients, but I just want to point out the Euroscore is slightly different. But I did want to point out that we had no stroke and really no mortality in our patients with the CoreNot series, partly because I will accept that they were somewhat selected with CT scans, etc. But what is interesting is that the pacemaker requirement is very different in the sutureless valves compared to the sutured valves with CoreNot. And of course, I do think the gradients are pretty good with the Trifecta valve, even in small sizes. So we kind of went with this approach. But we can discuss that later on. Now, the next important thing is aortotomy closure. We basically do it the standard fashion by 2 layers. We go, first one is sort of mattress up and down, and the second layer is an over and over. And for interest of time, I'll just move on because this is just, the view is very good with the camera in, and you can even allow your registrars to do it and watch every stitch. Of course, the main reason to do this is to be kind to the chest wall. You can see these are some of our post-op pictures. The one with a muscle builder was actually from Vinny Bappert. He's allegedly a UK champion muscle builder. And you can see how it heals very well, and he goes back to lifting weights much quicker. And the rest of these patients are some of my old frail patients. Now, the big question is it safe? One of my colleagues looked at our whole series over the last 6 years, and predominantly most of my colleagues are doing median stenotomy, and some of my colleagues have started doing hemistenotomies and anterior thoracotomy. And basically, we had about 100 patients in the two groups of hemi and ART. The take-home message really is that the cross-clamp time and bypass times are longer with anterior right thoracotomy, and that has to be accepted. Now, we had a slightly high procedure conversion rate, and that's probably because we had some new surgeons just starting off towards the end of that program. My own conversion rate is less than 2% in over 100 patients, but one has to be mindful of that. Now, again, we had very low mortality and stroke rates for our ART patients. And as you can see, the pacemaker rates are also quite low. Now, there's a lot of science to support smaller incisions, a lot of them from UK. Obviously, Enoch and Sukunai did some great randomized trials. Bill Kermani has kind of covered the whole thing in his paper for the Cochrane group. There are Italian patients telling us how, good these approaches are. And recently, Huneid has put together a very good review article about the advantages of it, and it really is a separate talk in itself. I'm going to just finish off by saying a lot of surgeons don't feel like they need to do anything new because TAVR seems to be going up and up. And certainly this is a slide from America where TAVR is going up and SAVR is going down. But I do believe, a bit like the coronary interventions, there is a need for us to innovate, and there will be a correction over time as long-term results start coming in. And it's up to us surgeons to innovate. Of course, everybody would love one solution for all our problems. Wouldn't it be great to have one animal for all our breakfast needs? We are not going to have one technology for all our aortic valve problems. And so we really do need to focus our efforts in improving what we do already. I'm going to finish off by saying there is enough science to support anterior right thoracotomy, but I think adoption is going to be the challenge. We really need a lot more support from industry and from societies. We need more fellowships. There are multiple amount of TAVI fellowships, but there are absolutely none for minimal access cardiac surgery. At the moment, Huneid is setting up what we're calling an artistry, which is the art registry between Bristol, Basildon, Harefield, and Blackpool. And if anybody is doing this and wants to contribute, we're very keen to have hopefully good quality data in about 5 years' time. And I think the future is even more exciting as we move to an endoscopic approach soon. Thank you very much, and please be in touch with whichever organization you fancy. Thank you.
Thanks, Joe. That's great. I think in the interest of time, if there's any questions, we'll get them posted on the Q&A, and there's time at the end, we'll get you to answer them then. But in the meantime, I'd like to introduce our next speaker, Dr. Gry Dahl, who's is a cardiothoracic surgeon in Oslo. She's also a director of ISMIX and is very active in the Transcatheter program in Oslo, where she's a consultant. So, Gry, thanks very much for taking the time. And I'm sorry that we haven't given you much time, but I'm sure it'll be very informative.
Thank you very much. So, as you understand, now we will move into the mitral area, and I have a special thank to Abbott for asking me doing this talk on my now 5-year experience with the tendon. Next slide, please. Next. They were not able to upload my videos, so you are showing my slides. Can you please forward? And forward. Mitral regurgitation is a heterogenic disease, and untreated it will cause heart failure and also later death. Next slide, please. Next. Mitral regurgitation. Okay, mitral regurgitation is a common disease, and incidence increased by age, and nearly 1 in 10 people above 75 years has moderate to severe MR. Next. For mitral regurgitation, there are several treatment options to eliminate the MR, going from medical therapy through catheter treatment to open surgery. Next, please. So, to find the right treatment, the patient has to be evaluated by the heart team. The optimal patient care is depending on the anatomy, physiological condition, and patient frailty. Next. The Tendyne valve was among the first transcatheter mitral valves in studies and on the market. And it was founded in 2010 and go through the early feasibility implant study and then acquired by Abbott in 2015. I will get back to this later. Next. The Tendyne valve is a 3-leaflet dual-frame porcine pericardial bioprosthesis. There are multiple sizes. The tether ensures anchoring in the heart. The pad secure anchoring and also helps to prevent bleeding at the access site. Next. The valve has a standard profile and a low profile frame. Altogether 13 sizes. And it goes from AP diameter from 26 to 41 and a perimeter from 96 to 143 millimeters. Next. Delivery system in Gen 2 is easy to use and gives a good control for the implanter, and the valve is repositionable, and the valve may also be retrieved. Then we need a special equipment. Next. So to evaluate the patient, CT reconstruction are done for anatomical suitability and procedural planning. Most important is to measure annular dimension and neo-LVOT, and also implantation angles and calculate the most suitable access. Although for all procedures, we do this poking on apex to find the best coaxiality. Next. So this is a video of a 3D print of a real patient's heart. It is the old system of the liver system, but we see how nicely the valve is sealing in the annulus, and and we see the tether and the pad positioning tool, and it's of high importance that the tether tensioning is held manually till the pad is in place. Then the final adjustment and tension is done to eliminate the PVL and neo-LVOT obstruction. Next. The procedure is mainly echo-guided, so you need echo people who are interested and can help you doing the procedure. Next. To train for the procedure, there are special cell simulators made now. It is truly realistic. It's human-like, and echo pictures are like perioperatively. And this is also very animal-friendly. Next. The early feasibility study for Tendyne made it possible to have the CE mark January 30th, 2020. Next. For the treatment options, it's mandatory to have a heart team to select the best option for the patients. And to the left, you see a flowchart how to do this. We did a study of our first patients, and it showed that 1/3 of the patients evaluated for Tendyne was not suitable in the anatomy and had to be reconsidered alternative treatment. Those had surgical replacement or repair, or a few mitral clip, or a few only medical treatment. But no, the screen failures rather are lower. Next. Next. For an optimal result, a successful implant has to be followed by postoperative optimal management like a surgical MVR. Inner-probes may be needed and to avoid giving too much volume. It is important to start postoperative anticoagulation with Coumadin early, bridged by heparin, and early mobilization and pain management to avoid pneumonia. Next. Next. So the first global study, the first acute case was done November 2014, and later that year, the first patient was included in the study in Australia. Then the first patient in Europe was included in our center in the early feasibility study, and our center had also the number 10 in the total study. CE mark was achieved in January 2020, as I mentioned, and no 600 patients have been treated. There has been started the post-marketing study, Resolve MR, and also in the US, the Summit trial is going on, comparing MitraClip and Tendyne, and they also are armed with MAC. Next. And here we see a celebration of our patient, of the patient number 100 in the study. Next. So for the 101st patient are now followed for 2 years. Our center have 6 patients included. Next. The study enrolled patients with severe symptomatic mitral regurgitation, not candidates for surgery. We had the exclusion criteria of left ejection fraction of below 30% and left ventricular and diameter of 7 centimeters and severe mitral annular calcification. The age are a bit below what we would expect for the TAVI patients, and there are many patients with heart failure hospitalization. And STS prom was about 8. Next. So important is that the success rate was high. There were no procedure mortality and no emergency surgery. 30-day 1 and 2 year mortality is acceptable with the high morbidity. NIA class was 3 was in 62 persons, and as I mentioned, STS prom 8. Next. The elimination of MR sustained over 2 years. Next. Also, the NIA class and quality of life significantly improved and is kept. And NIA class 1 to 2 was achieved in 82% after 2 years. It's a great value of treatment for the patient. Next. There is a 47% reduction of heart failure events per patient year. Next. Next. As I mentioned, initial MAC was exclusion criteria, but now it's shown to be a good indication. And these are the first patient studies with very good results. Next. Taramasso et al. Showed the feasibility of implanting Tendyne in patients with previous aortic valve replacement, surgical or TAVI. And we know all that for a surgeon it's very painful to do mitral valve replacement if the patient already has an aortic valve replacement. Next. Next. Yeah. We had a patient with Evolut Pro, a TAVI, and MAC. He had multiple heart failure hospitalization. We did a successful procedure, and he had very good clinical improvement and no heart failure admission at the 6 months follow-up. Next. Here we also see the nice tissue ingrowth. This is a patient who had a heart transplant 10 months post-implant. Next. Here we show our first patient that is now 5.5 years since his procedure. And this recording was done 3 years after, but he is the same. He is doing very well and is working and has a very good life. And he was in severe heart failure when we did the procedure. Next. So thank you so much. I made this overview if you want, you can read more. Now I'm available for questions. Thank you very much.
Thanks very much, Dr. Dahl. That's a great presentation. There's just one question from one of the faculty. Is frailty an issue with this approach? So I presume if you're a frail left ventricular apex, is that a problem or?
Of course, it's a problem, and I'm also always very careful if the patient has been on long time steroids and so on. So we always evaluate that. But we have figured out there are very, very few apical problems with the tendon compared to the other mitral valves, transapical placed. And I think that the pad is one of the reasons that the problems with apex are so small.
Great. We've run over time, so thank you very much. And on behalf of Abbott, I'd like to thank our other presenters. It's been a very informative soul-searching meeting, and I've learned a lot from it, and I'm sure the audience has. It's difficult doing these meetings over Zoom or virtually, and I'm just hope that next year, SCTS, we can do this all in person. So thank you to the speakers, thank you to the sponsors, and thank you to SCTS.